Can I ask everybody, if you want to ask, and if I miss you, and you feel I've not addressed, agenda. So if I appear not to be looking at you, I'm not being rude. Okay, and as we've just heard from Chris, from the people handling the Welcome everybody. Can I just first of all go to apologies? I've been notified of apologies from Dr. John Patterson. Deb, do we have further apologies?
Yeah, we've got Erin Portsmouth and Mike Barker.
Right, thank you very much. On the housekeeping, just as I've remind everybody, this is a live meeting and is being recorded and will be broadcast on YouTube from now on. Raise hands if you need to draw attention to or want to make a point or a question. Thank you. Declaration of interest. Does anybody have any changes, additions or deletions from the current register? Is there anything on today's agenda which strikes everybody that they may have an interest? Ian. You're on mute, Ian.
The discussion around the hubs includes in the title Saddleworth Hub, which is clearly where I work, but I think you're largely talking about the other two sites today.
Thank you for that. And if just to complete the statement, if anybody becomes aware of anything during the course of the meeting in which they believe they or any of your colleagues have an interest, please let us know so we can discuss and decide how to continue. Thank you. I don't propose to go through every page of the minutes of the last meeting, and hopefully you've all had time to read them by now. Does anybody have any comments, corrections, additions? So we can take those minutes as a true and accurate record. Thank you. Kate, I think item number 5 is the outline business case for the Oldham Health Hub schemes. Over to you, Kate.
Yes, thank you. I hope everybody has had a chance to read the papers. I'll give a brief overview. So GM Health and Social Care Partnership have offered a capital grant of £3 million, which requires substantial works of £500,000 to have been underway by the 31st of March 2022, which is the end of this financial year. The CCG has been developing outline business cases for 4 priority sites, being Chadderton Broadway, Chadderton Wellington Street, Shaw Crompton and Saddleworth. And that was to understand the options which are deliverable at a cost neutral impact in respect of practice rent reimbursements and costs. Having reviewed the outline business cases, it's the recommendation of the paper to PCCC that we approve to progress the Shaw Crompton development as that is the only cost neutral option. This would support the ability to deliver those substantial works by the required deadline of the 31st of March 2022, which would mean that the risk of the capital grant being lost to the Oldham economy would be achieved, which is obviously a significant concern for that to disappear. In addition, we request the approval to progress in addition to the approval to progress the Shaw Crompton development, we request approval to delegate to the CCG leadership team the assessment of the revenue impact of the possibility to progress the 2 Chadderton developments. So recognising that that's not part of the affordability within that capital grant, actually looking at the revenue impact of continuing those developments, and that piece of work will come in future years if that delegation is approved.
Thank you, Kate. Any questions from anybody? It seems to me a very sensible way to make progress and to ensure that the funds stay within the Oldham economy. And I think it's important to note that these are quality improvement projects essentially, and anything that improves the quality of care to the people of Oldham is to be welcomed and embraced, and we mustn't let it go. It seems very straightforward to me. So does the committee agree the first request is to progress the Shore-on-Crompton immediately, and the second request is to delegate authority to the leadership team for the 2 Chatterton projects to continue as well? Right.
To assess,
Yeah.
to assess the revenue consequences should that be the case. Just wanted to clarify that wording, please, if you could, Chair.
Thanks for that clarification, Kate. So I've not seen any dissent, so both those requests are approved and okay. Thank you very much for that.
Many thanks.
Is Marion on board now for item number 6, primary care quality and assurance report?
Yes, Chair, I'm here. Thank you. Would you like me to start talking through?
Yes, please.
Thank you. So since the last primary care commissioning committee, the results of the inspection, the CQC inspection at Moorside Medical Practice have been published. Unfortunately, the practice has been rated inadequate overall. Well, they have retained a good rating in 2 of the 5 key areas. 3 were deemed to be inadequate and therefore led to the overall rating. At the time of the CQC inspection, the practice were experiencing significant staffing pressures. The contract is held solely by Dr. Kieran Kaur. However, at the time of the inspection, her 2 salaried GPs had both left. Some members of the nursing team had also resigned and left, and they were struggling. I'm really happy to say that they have now recruited to their salaried GP posts and to one of the nursing posts. However, the issues found were by the CQC inspectors were predominantly around their management of serious incidents, around clinical supervision and clinical audit. In respect of support for the practice moving forward, they have been referred to the RCGP programme funded by the GP Excellence team. They're now linked in with that team and working with them. While they continue with their recruitment process, the CCG has put 2 days a week support in there of a clinical pharmacist for them to give them some additional clinical time. And one of the CCG quality nurses has done a great deal of work with the practice, looking at their management and review of incidents around reflective practice, clinical audit, and supervision. Ourselves in the primary care team have been doing a lot of work with them around the governance, policies and procedures, and supporting them with their responses to the Care Quality Commission. So the practice are engaging well. It should be said about Moorside Medical Practice that their access is exceptional. They're one of the highest rated practices by patients in Oldham in respect of ability to get appointments, satisfaction with phone access. And indeed, their patients have been very supportive of them throughout this whole process, and patient satisfaction with the care and quality of the service remains high. And I would like to reflect that back to the committee. They are engaging well. They are on a journey, but I think the early indicators are that in 6 to 12 months' time, this practice will be looking at a very different and much more positive outcome at their next CQC inspection. We will be staying in close contact with them and following the formal primary care management panel that took place the week before last. We'll be informally meeting with them on a monthly basis.
Thank you, Mary.
Okay. Sorry, Chair.
I was just going to ask, does anybody have any comments or questions at this stage? Andrew, I think, are you?
Yes, I just wanted to thank the CCG and Marion for inviting me as part of the LMC to that meeting. I thought it was a really positive meeting. I found some excellent clinicians and staff who really wanted to do the best for the patients of Oldham, and I felt it was a really positive meeting to support them. So that, and I agree with Marion, I do firmly expect that this will be a very different situation in 6 months' time.
Thank you for that, Andrew. Good. Thank you for that, Marion. It's encouraging, isn't it, when we see a practice that the patients love, that have such a good access, such good rapport, and that they should embrace all the help and offer and support that as a CCG we know we can bring to them. So we look forward to them working with them successfully in the future. Thank you for that, Marion. Do you want to continue?
Thank you, Chair. So moving on to the CCG quality assurance visits, and these are the visits that are taking place under our new quality assurance programme, or revised quality assurance programme, I should say. You'll remember at the last committee we asked if we could progress the visits without clinical representation at every visit, because that was proving problematic in respect of the timetabling. However, we will co-opt in clinical support should we find at an assurance visit that is needed. That has allowed us to get the visits really underway. And since the last committee, we've been to the village, to Wearmouth Medical Practice and to Medlock Medical Practice, with more visits scheduled over the next month. The village, as you can see from the assurance scorecard in Appendix 3, performs very well, very highly against all the quality indicators in there. We found very robust systems in respect of governance at the practice, and we had no concerns there. However, the practice is currently experiencing significant staffing challenges, and at the moment is being staffed, its GP workforce is largely being provided by locum GPs, which isn't a situation that long term would be desirable. So we will be asking the practice to submit an action plan back to the CCG within 28 days about their plans in respect of recruitment and retention of GPs. I don't think this is indicative of a longer term problem. I just think that they've had a flurry of people leave. However, it is very important that they bring some stability back to the GP workforce at the practice. But overall, and as I said at the start, as you can see, this is a high performing practice against all the clinical indicators in the scorecard. So we didn't have any concerns there. We've also been to see Dr. Butt at Wearmouth Medical Practice. Really happy to say that Dr. Butt is going to be moving into his new premises later this month. And this will be the last old terraced house GP estate in Oldham, which is really good news for our patients and indeed for staff working at the practice. The practice are really excited about the move. They're really excited about the opportunities that will bring them to be in appropriate estate, as it will allow them to expand the range of clinical services that they can offer to patients, which they currently can't do because of infection control guidelines and the building that they're currently in. The practice has struggled for some time now in respect of nursing staff. So I'm really happy to be able to report that they have just managed to recruit a practice nurse and a healthcare assistant who are permanent members of staff at the practice. We will be asking for an action plan from them. As you can see from the assurance scorecard, they do have significant pressures in respect of childhood vaccine IMS uptake, in respect of cytology in some areas of chronic disease. Of course, with long-term nursing vacancies, this has been very challenging for them. However, Dr. Butt is acutely aware of the numbers he needs to do, and he does have robust plans in place to change that picture in the next 6 months. We will be keeping in very close contact with him about that, and again, looking to the Winter Access Fund and how we can further bolster practice nurse and advanced nurse practitioner access, sorry, put my teeth in, within our primary care networks. Dr. Butt, the governance at Wearmouth Medical Practice is good. However, as a small practice and sole contract holder, responsibility does seem to sit with Dr. Butt by himself. However, again, he's just recruited a new practice manager, and we're going to be working with her to support her training and development and buddying her up with one of our more experienced Oldham practice managers to try and relieve some of the pressures there for him. So some challenges at Wearmouth, but really robust plans in place, and really happy to see the progress that the practice is making. We've also been out to Medlock. The report, this was a very recent inspection, so the report is not included in the papers as it hadn't been typed yet. However, generally, again, very good governance at this practice, very resilient due to the structure of being part of the Beacon Group with, you know, so many practice managers and clinicians to draw on from across the group. However, this is not always reflected in some of the clinical outcomes, again, as you will see from the assurance scorecard. So again, with this practice, we will be asking for an action plan to be returned within 28 days around childhood vaccines, around cancer screening, and around some areas of chronic disease management. Overall, the assurance visits are progressing really, really well. It is a pleasure to have the time to spend time with all our GP practices in Oldham and to hear from them what life is like, what the pressures are that they're facing, and to try and put structured support in for all of them.
Thank you for that,
Thank
Mary.
you.
Any questions or comments? Claire?
Just more of a comment from me, really, but just listening to the wealth of information that Marion's just shared, and how getting the framework and the assurance visits set up is starting to bring through this real depth of intelligence and information about quality of care and experience. I think is really, really valuable to all of us as a system and to us as a committee. So a huge thank you to Marion and the team for the work that's been sustained in doing that. And I think particularly for me, hearing some of the lights at the end of the tunnel in terms of recruitment, particularly around nurse recruitment, is particularly welcome, given the sort of the areas of concern that we've had around childhood IMS and long-term conditions, etc. I'm really happy to hear that. So again, thank you.
Thanks, Claire. Majid?
Yeah, just building on what Claire said, really, the assurance visits are proving their worth in terms of identifying all the good stuff and areas for improvement with robust action plans coming up to follow, rather. It's all really, really good to hear. In terms of broader learning, so as we do these visits and we pick up themes or specific challenges or even good practice and stuff, I'll be in a position where we are sharing this with other practices. So visits done, this is what we learned, this is some good stuff, this areas to look out for other stuff. So that was the first thing. And second thing, did I hear you say that no more practices in terraced houses? That was the last one done, which is again is absolutely brilliant news. Really, really pleased that has happened, and patients are able to access facilities which are fit and proper for the services that they need. Really good news.
Thanks, Majid. Important points, those. Marion?
Yes, thank you, Majid. In respect to the sharing of learning, we're still in quite early stages of the assurance process, and we're still waiting for these initial action plans to come back. I think the value for us in going around all the practices in this way is that we have started to do that, and on a more informal basis, because I hear about good work at Kapoor Family Care. I hear about good work at Saddleworth, as I'm looking at you, Ian. And as I then go to the next practice, I, say, right, you might want to speak to them. You may want to buddy up with this practice. What we have to do, Majid, and what we will do next is formalise that by pulling all these individual reports together. We have our first Practice Manager 500 club the week after next, which will be our first one, as they were stood down last year for obvious reasons. And we are already incorporating some of the learning from these quality assurance visits into that afternoon as we talk about CQC inspections, quality, and just those general areas that we all need to be acutely aware of and look out for.
Thank you very much indeed for that, Marion. Ian, you wanted to come in?
Yeah, thanks, Chair, and thanks, Marion. I agree with everything you've said. This is a really important piece of work, not just for identifying good work and finding gaps that will help practices get through future CQC inspections, but there's a connection, isn't there, with commissioner and provider that's really important too. I just thought I'd share something about, practices and training. We have a number of practices in Oldham that are training practices, and that is a good way of getting recruitment into the practice. 5 of our doctors trained at the practice, so it does work. And we've taken undergraduate nurses from Salford for the first time last year, and as a result we've got an excellent newly graduated nurse who is following the academic practice nurse pathway now, who is worth her weight in gold. So I know workforce is an issue everywhere, but there are some ways in to try and give yourself an edge. And if you're willing to put the time in and train undergraduates in a number of specialities, and we've got a paramedic sat around with us at the moment as well, it can pay dividends. So it's worth thinking about for practices who feel that's something they would like to do.
Thanks for that, Ian. Marion, are you complete now?
Yes, thank you, Chair, unless there are any more questions.
From the comments we've had and in a number of the visits, you've talked about staffing levels. Ian's just talked about staffing levels as well. And that's a very nice segue and introduction to Tarek, who in fact is here to talk to us today about primary care workforce update. So the timing couldn't have been better.
Thanks, Graham. Thank you for that. Yeah, I've pulled together say a short slide pack. It depends on what your definition of short is, but yeah, just looking at some of the key areas at the moment of work. So if it's okay, I'll just talk through those briefly, and then if there's any sort of questions or comments or a wider discussion, that would be really welcome. So I'm assuming everyone's got some visibility of the slides and they can see those. Okay. So what I've included here is the nationally publicly available data for a primary care workforce breakdown. And I think you probably remember about 4 years ago, we had to go through quite a significant internal exercise to get some accurate workforce data. The good thing is that this is mostly extracted directly based on a snapshot in time from practices themselves. So this data is what the practices have told told NHS England is their current situation. But it is literally lifted at a point in time, so it could have changed. It could have been different literally the day before, and it can be very different the day after. But it gives you a feel for the workforce numbers. Just to say that comparing it back to 2017, it hasn't changed a huge amount, although interestingly our headcount is probably reduced, but our whole-time equivalent has probably increased, which suggests that there are more people doing, less people doing more work within general practice at the moment. The GP situation is actually slightly better, but I think it just needs to be a caveat around the validation of the data maybe a couple of years ago. The headcount is broadly the same, although the whole-time equivalence has increased. quite significantly from around 119 to about 156, although that does include some of the locums and the trainees. And I think, as Ian's already said, we have slightly more training practices now than before, so some of this does depend on how practices submit that data, and it is open to their interpretation of who's in the practice on a given time. Slightly disappointingly, is the number of nurses in that 4-year period has decreased, probably by about 25 in terms of headcount, and the whole time equivalent has come down from around 75 4 years ago to 61. And I think when you look at the age profile that I've included later on in the presentation, that kind of hasn't changed hugely in terms of the age profile, particularly of our nurses, with nearly 60% being aged 50 or over, and around a third of GPs, when we exclude trainees and locums, are aged 50 or over. So I don't think this is that much of a surprise, because I think we're all aware that continues to be, those two areas continue to be the areas of the greatest concern in terms of practice staff. So I'm not going to specifically dwell on the tables, and I guess that if I come back and present this, it might be useful to maybe look at these compared to the next submission compared to this submission, and we can start to plot some of these trends as well. I've aggregated the data based on a PCN basis, and I think what we're trying to encourage our network managers to do now is to start having that discussion at a PCN level around what their core workforce looks like, because I guess that impacts on the resources available for network delivery. But it also encourages maybe some new ways of working and some sharing of staff across PCNs to help bridge some of those vacancy gaps or those vacancies that we currently have. So certainly that's a message we've put out to our network managers, is to start maybe looking at this as practices within PCNs as well, and seeing how they can approach some of these things together. If I just skip to slide 11, you can see here, this is just a graphical representation of that age profile I've spoken about before. Particularly on the nurse chart, you can see those figures supported there in terms of the aging profile of our nurses. We've tried to do sort of something relatively innovative in Oldham in the last 12 months, which is we had a pilot to bring in some trainee practice nurses. So looking at qualified registered nurses who've been working elsewhere in different care settings, and trying to bridge some of that, the gap between what they can do in their role outside of primary care and their readiness to actually take on a practice nurse role. So we took on 5 nurses and we part funded that, and the practices where these nurses were placed contributed 50% of their salaries as well. And we tried to shorten the training period, so it differs slightly from, say, the GPN Foundation programme that probably Ian's got experience of in his practice, which tends to take place over a longer period of time and has a slightly different way of dealing with sort of the salary contribution. So we took on 5 nurses in December. They were on a 6-month placement. The CCG employed them, placed them in 5 practices in Oldham, and we supplemented their training, gave them some internal training, brought in some external providers as well, and then at the end of the 6 months, we obviously hope to place them into general practice. So please say that of the 5 that took part, 1 unfortunately did drop out halfway through. It wasn't quite for them, and then unfortunately one of the other 4 who went on moved for relocation reasons, but they'd actually have gone on to a practice nurse role elsewhere in the system, unfortunately just not with Oldham, but they've gone with our best wishes. I'm pleased to say that 3 have stayed in Oldham, and I think we've proved the concept, and I think we accepted that there are definitely things that, with that being wave 1, and probably don't launch a pilot in the midst of a global pandemic, but having accepted that there were some limitations and some areas of improvement, it's something that we would be interested in doing if we can sort of bridge the gap, particularly around the CCG transitioning to an ICS. So there are some discussions about how we might look to do something similar. I think one of the issues that we found when it came to employment is quite a few practices would favour having a part-time nurse, but obviously generally the nurses we brought in were maybe younger than some of the nurses are currently who are working in Oldham, and obviously they tend to favour full-time work. So I think that's definitely an area that we could maybe utilise PCNs or practices working together to look at how we might effectively employ them full-time, but deploy them across a couple of practices, or as a PCN resource as well as a practice resource. So it's certainly something that we're looking at. In recent weeks, I've had a discussion with Louise Thornton around how we might run something on an Oldham level in conjunction with the GPN Foundation programme, and maybe look at a hybrid of the two, and where there are some common areas where we can get those working together. We have sort of referred on quite a few practices to the GPN Foundation programme, and I think the take-up is looking pretty good for that as well. So I think there are some areas there that we can improve on, but I think we are trying to do what we can with regards to improving the practice nurse numbers in Oldham, recognising we are where we are with that. From the GP front, some of the GP retention programmes had to take a backseat during COVID, and some of the things that we were looking at doing on a local level have been picked up more on a national level in terms of increasing GP trainers. So that's something we're eager to get up and running again, and really look at how we can build on that and keep more GPs in Oldham. So on slide 12, I have just provided a breakdown there of the different roles that GPs are in within practices. So certainly I think our locum usage has gone down considerably in recent years, which is obviously whilst locums fulfil a very important role and they are a valuable resource, it's obviously encouraging that, you know, we've got more people staying within Oldham. So that's kind of where we are in terms of the current workforce profile, and I'd be happy to come back and give you some additional information on that in coming months. In conjunction with sort of looking at what we currently have out there, an important thing that we have been doing since sort of March last year is engaging with practices and keep an eye on what it actually looks like for them on the ground in terms of the numbers of staff and how they were impacted by COVID. So we've sort of stepped up these reports more frequently when we needed to, and then stepped them back down, mindful of the impact on practices' time to submit it. So we currently just get this data once a month, because the number of staff absences, particularly in terms of, you can see there on slide 15, in terms of the percentage that are actually self-isolating or off due to COVID reasons, has stabilised and reduced significantly, and we've not seen the sort of spikes that you would have seen on the charts on slides 16 and 17. You know, in terms of when obviously we're in the the height of the pandemic, particularly last winter and when it first began. So things have generally stabilised. What we also do is we don't just go out and take the data, we get in contact with the practices who may not have submitted, or who've if things have significantly changed or they've got a high proportion of staff off, and we do a temperature check with them and see what support they may require, and any difficulties they may be having. So we do try to reach out to practices as well off the back of that. It's not just a data collection exercise. The next section looks at additional roles, and again I think this obviously ties into the general workforce picture. In terms of broadening the primary care roles that are available, and also looking at the delivery of some of the PCN DES requirements as well. I think Oldham's position is not drastically dissimilar to a lot of other localities in GM and elsewhere across the country. There have been issues generally in terms of employment risks being taken on by practices, and it tends to work better when there's a subcontractor model, which we found with some of the progress we've made so far in Oldham. So in terms of what we've currently got in post, the majority are social prescribing link workers, which were taken on sort of in the last 12 months. And there's been a lot of really good work done with the Northern Care Alliance around first contact practitioners, which are obviously physios as well. So that's been a really positive step to get those in. I think obviously again, Ian, you've had some practice, some experience of that in your practice with the physio model and the first contact practitioner, and that's worked really positively as a pilot, which has been the basis for some of this work. There are discussions underway with regards to mental health practitioners, and the Pennine Care are out to recruit for those roles at the moment, and we're hopeful that we embed one whole-time equivalent into each PCN, which is the current maximum that you can have for an adult mental health practitioner. And hopefully, if this works and it's successful, we'll look at then taking up the option of potentially looking at children and young persons mental health practitioner, which is also an available opportunity. We've just done a sort of a planning exercise with our PCNs, and the most in-demand roles, perhaps unsurprisingly, are clinical pharmacists, the pharmacy technicians to support them, and paramedics. So they're a work in progress. I know that, again, Ian, it's not picking on you, but you've mentioned about the paramedic in your practice. We know that there are paramedics in other PCNs as well. They tend to have been done more on a practice basis rather than a PCN basis, and there are some significant challenges for getting them in PCN wide, but we're looking at how we can do that. In terms of the other roles, they are very much down to individual PCNs, and there is a little bit of difference between who wants what depending on what they would require. So I think what we've done in the last 2 months is we've now put in an R's implementation group that we can focus on the delivery of these plans with the PCNs and help to remove some of the barriers and the challenges that are in place and stopping them from getting the roles out to recruitment. So we're looking at the broader plans and seeing how we might be able to assist as a CCG, or potentially look at specific PCNs leading on specific roles, and hopefully my hope would be that we would recruit to our full financial available, the funds that are available across Oldham. We would hopefully utilise that at some point within the next sort of 12 months realistically, bearing in mind this current wave of PCN recruitment is due to end in 2024 for ours. So that's where we are with ours at the moment. And then the final thing I just wanted to focus on is just around some of the training that I think has obviously been mentioned, you know, at the beginning of this meeting as well. So we went out and we did a mini training needs assessment with nurses and HCAs, and it was relatively well received in terms of the responses we got back. The good news is, if you skip to slide 25, is the interest across these different areas, and it was mainly from nurses with some HCAs, but was broadly in line with kind of what we were hoping to deliver anyway with training. So we do get CPD funding that comes in via the GM Training Hub through HEE, and so that's quite restrictive funding, and it tends to only be for nurses and allied health professionals, but we would hope to use some of that money to deliver training in these areas. So we're in discussion with a number of providers to actually deliver them specifically for Oldham. I think the nature is of external training is they tend to, particularly during COVID, they tend to only run courses maybe 3 or 4 times a year, and at relatively small numbers, and if you miss one in July, they might not have another one until February next year. So it's like they fill up very quickly, and you tend to wait. There's fewer rolling on and rolling off options for these courses. So we're in discussion on slide 26 around delivering. Hopefully this will be the plan within the next few months. Is we'll have Oldham specific courses that we will then offer out to our nurses, and if we don't quite get the take up for our locality, we'll take the offer that's been kind of extended to us by the GM localities, is that if there are a few spare places, we might then offer that to other GM localities as well. So we're hopeful to have a really comprehensive training program delivered before sort of the CCG comes to an end at the end of March. So our preference would be to try and put on some face-to-face training, providing that we can do that safely and in a way that's suitable for everyone. But we also did run sort of an Oldham course last year online that was really, really well received, that we aimed at our trainee nurses, but we opened it up to the other nurses, and that was run by the Faculty of Sexual and Reproductive Health, and that went really well. So we would be open to try and deliver that kind of training on a local basis for us, and we'll get as much of that off the ground. So just onto the final slide. So in terms of the current work streams that we would like to keep going and try and fulfil our potential for, we're going to look into the viability of another nurse pilot and try and improve on what we did and maybe do that again. The GP retention programme we will continue with. We've put in for a small amount of workforce collaborative funding, which would be tied to our nursing pilot, although our nursing pilot isn't dependent on receiving that funding, but it would obviously mean that we can then essentially increase the CCG contribution and potentially look at maybe extending the length of our pilot if that's appropriate, based on some of the feedback from the practices that took the original placements. The next one, I'm really keen to get moving on, and it's something that's I know is a challenge, but we've got some really good opportunities if we can get people placed into practices for work experience or to supplement learning elsewhere. So in Oldham Sixth Form College, they're currently running T-levels for nursing, which is the sort of the vocational version of an A-level. So we've got a really good opportunity to support the college and to get some 16 to 18-year-olds who want to become nurses into Oldham practices, if we can overcome some of the issues around things like estates and making sure that we can provide sort of placements that are sufficient quality both for the practices and for the students on those. So that's a really good opportunity for some a medium to long-term solution for improving some of the vacancy rates we've got for key areas, particularly around nurses. And we do get approached relatively regularly for placements in primary care. So that's definitely something we're interested in looking at. The training I've already touched on. We've just recommissioned some care navigation training to supplement some training that was done as part of the primary care reform work a couple of years ago. So we're quite eager to build on that and link some of the good work that's currently going on in practices on a system-wide basis. We'd like to try and get the primary care workforce group re-established. It's a really useful forum that for discussing some of these things and looking at the workforce programme, even if it's, you know, hopefully then it's sustainable beyond March. But it was a really good place for getting people who are enthusiastic about workforce together to look at some of the plans and also getting feedback from within primary care itself. And then obviously going forward with the RS schemes, and that what I've not included, although it's just come up as well, is some involvement with the Kickstart programme, particularly working with HMO's Primary Care Academy, and there's some opportunities there for sort of generally young people, but people who are interested in working in primary care, more on the admin side, and getting some of those into Oldham as well and taking the opportunity that's afforded to us there. So there's kind of a lot going on, and there's a lot of work to do, but we're, you know, in terms of, you know, trying to focus on key areas, I think we're looking in the right places. It's just a case of delivering on those.
Thank you, Alice. Tarek. Derek.
Just a comment. I'm not sure if I'm comparing apples and pears, but I read on the internet that the average GP in the UK is looking after 2,000 patients. If I do a calculation based on these figures for GPs that are on these lists, and taking the population of Oldham as 250,000, then if we've got 192 GPs, the average patient per GP is only 1,300. And if I take it on the whole time equivalence of 157, looking at an average patient per GP of 1,600, which would suggest that we're quite well served in terms of GPs per patient. Am I comparing apples and pears, or is that right? Are we very, very good in terms of GPs per patient?
So, well, the answer is, Derek, is I know how many GPs we have per 1,000 patients in Oldham, but what I've not had the time to do is to go through and look at the other GM localities. So the way this data comes out, it comes out in a big sort of unhelpful spreadsheet, and you have to go through and pivot through it. So it's maybe a job for our BI team who could do that, and Ian's wants to jump in on that anyway. So
yeah, but I'm looking at a figure for the country as a whole is 2,000. I didn't GM have no idea, but the country as a whole is saying it's just breached 2,000 now patients per GP.
I think Ian wants to jump in at this point. Do you, Ian?
Yeah, so it's a bit of a blunt instrument, the number of patients per GP, because if we look at the last 20 years, what we do in primary care and how many contacts we have per year, you really expect double the workforce that we had 20 years ago. And clearly we haven't got that. We also have a blend of so many healthcare professionals joining us, as Tarek very neatly outlined. So just counting GPs, it's all about what services you provide. It's about what roles you have sitting alongside you. When I was a GP many years ago and joined general practice, we had a red book, and you're right, you got those numbers you quoted were about right, and there was only GPs that could directly look after patients. So I think it's a antiquated way of looking at things. It's a statistic, but I don't think it's helpful to look at workload or how we get a blended workforce.
Thanks, Ian. Thanks, Dave. Andrew was next. I think he put his hand up there as he's wearing his LMC hat. Is that correct?
Yes, indeed. Well, actually, I'm interested in this from all my hats. Tarek, the training and stuff going on with the nurses, I see it as such a need in Oldham to get good quality young nurses coming through very early on. And there's all the changes going on in the CCG. I just wanted to ask how resilient is this, and how will it run moving forward? Will it continue as previously happening, or what's the plans to keep it going?
Are we talking about another version of the pilot that we did, or are we talking about just generally the workforce programme as a?
It's particularly the nurse training, because I think that's an area that I was completely behind it whenever it was starting, and I'm still behind it, and I'm aware that surgeries are struggling with nurse recruitment and nurse retention, and I think it's an area that needs to be one of our priorities as a health economy.
Well, I think, and Claire, you might have an opinion on this as well. I think with the I think in terms of the nurse pilot, I think the only issue around it is around funding, and it's like, well, how can we balance that contribution between a system and practices, accepting that the nurses are not necessarily ready to go from day one. I think there needs to be a bit of acceptance within the system as well around what a new to general practice nurse can do from day one as well, because they're not going to have those 20 years of experience of, say, chronic disease management. So certainly for the pilot we did, it was a focus on things like we got them, they did their smear training, then were undergoing the assessment, they did their IMS and VAC, so they could do some things from day one, but then to obviously supplement that. So I think the concept has been proved as being successful. I think it's just trying to iron out and make it work better. So from my perspective is I will be quite hopeful that we could do it again, and that then someone else would pick it up, and it would be maybe down to the practices or the PCNs to look at the employment. I guess from a CCG perspective, our question at the moment is around some of those employments beyond the 31st of March. Now, we would obviously we need to give the nurses the security of a contract that they know that they're, if they're going to leave one job for, they're going to take a job where they've got some security. And also, whilst we stop short of assuring, of a job at the end of it, I mean, if we could get to that position, that would be fantastic. But also some of those things around to say that we'll make sure that they can get a job in Oldham at the end of it. Otherwise, it's almost a pointless thing if we lose them elsewhere. And then hopefully some of that moving around that you get of nurses across practices, the more nurses we can get in, then the better it is, and that's less likely to happen. Is that okay?
Thanks. I think Claire was next on the way I've got them down. Claire?
I think it was Marion, but it does follow on to that point, if you don't mind me jumping in, Marion. No, just really welcome the conversation in terms of recruitment and retention, particularly obviously of nurses, but across the board. And I think Tarek's right, that there is a real proven success there with that pilot, that we would want to look to see how we can replicate that with all of the things you've just discussed. I think the point I wanted to make was linking that back to a discussion that was held this morning at the Oldham System Board. So the new kind of system governance board that is finding its feet, and very much an in-depth and unanimous discussion about how we bring our workforce together, how all of the ambition that we want to see in Oldham is dependent to a certain extent on the workforce, and how we need to make sure that we are looking at recruitment, retention, and I think it is a mix, because as Tarek said, that those newly kind of qualified nurses coming through, the college students who are having the practice placements, but it's also about how we retain the experience in the system to be able to bring those less experienced nurses, AHPs, GPs as well, how we bring that forward. And I think that's the really important thing that we need to get behind as a system. So really welcome this as a conversation, and I think there's some real opportunities going forward for that.
Thanks, Claire. Marianne?
Thank you. I was going to talk about nurse training, but I think all the points I was going to make have been picked up. But there is just one more thing, Tarek, that I just wanted to elaborate on a bit more from your presentation, was around care navigation and why we're rerunning that. We do think at the moment, especially for general practice, having a front desk workforce that are able to signpost and navigate patients to the most appropriate place to receive the support and help that they need, which is not always general practice, because despite the pressures on general practice does remain one of the easiest parts of the healthcare system for patients to access. And as a result of that, many patients do present with housing issues, social care issues, issues that general practice cannot resolve. So a large part, so it is a really important work stream at the moment, that care navigation. And why we're revisiting it is, I think we've learned a lot from last time we delivered that training in Oldham. Last time we delivered it in Oldham, it was very much focused on the principles of care navigation, how to do it, why it was important. But I think what we've recognised is that perhaps what was lacking was the pathway work to support people to navigate at the front desk. And that's why Tarek's been revisiting that training programme, because you've got to have somewhere to navigate to, and those services have got to have the capacity to accept the patients once they are signposted there. So it's now looking at care navigation in its broader sense, and that's the piece of work that Tarek's currently been looking at. And just finally, to reflect back to you, Tarek, I know there was a lot to learn from the nurse training programme, but the fact that it was done during the COVID pandemic, the fact that you did source the training when training could be stood down, and the fact that 3 of those nurses did stay in Oldham is actually really, really significant. So it's a really good piece of work. And yeah, let's see if we can build on that for next time. Thank you very much, Tarek.
Thanks, Marion. It seems very clear to me that this is a substantial and important piece of work. And the one thing that stood out for me is linking back to, if we recruit, if we train locally and develop locally, people stay locally. A point I think that Ian made very forcefully, and I think it's so important. And it's not just an academic or a paper exercise. It really is important. And it's good for employment in the town as well, and good for development of young people, and good for the care of our community by local people, for local people. A really important piece of work. Thanks for that, Tarek. I think that brings us to the end of the agenda. Other to discuss any risks that we've noted and highlighted. I can't think of anything that stands out. Thank you. I've not been notified of any other business. And the date of the next meeting is the 20th of January 2022 at 2 o'clock. Thank you all ever so much for your time and attention today. Bye-bye.
Thanks, bye.